Okay. Good evening, everybody. Welcome to the 30th episode of our Diabetes Bytes, an initiative from RSSDI. It's our social media connection. We're live on Instagram and Facebook and YouTube. So you can watch us every Thursday from 7:30 p.m. to 8:30 p.m., answering all your questions related to diabetes with some of the best experts you can find in our country and from abroad. Today, the topic for today's discussion is diabetes and thyroid dysfunction. Are they an intertwined condition? And to speak about it, I shall be asking questions to our beloved endocrinologist and one of the most famous endocrinologists from India, and none other than a good friend and a well-wisher of mine, Dr. Krishna G. Sheshadri. Dr. Krishna G. Sheshadri was former professor of endocrinology and head of Department of Endocrinology at Ramachandra Medical College. He is a well-known researcher, a great speaker, an intellectual, I could call him so, and he will answer all your questions on diabetes and thyroid, how they are interconnected. And the other thing about him is he's deeply spiritual in terms of his connect to everything in the world. I know him well. So few words, and he also was the former secretary of the Endocrine Society of India. He's on various editorial boards. There's a brief about Dr. Krishna G. Sheshadri. Welcome, Dr. Krishna Sheshadri, to Diabetes Bytes, and you're going to be grilled for the next 1 hour with questions. Welcome on behalf of RSSDI, and shall we start, or you want to say something?
Nothing. Hello, Sanjay Amin Sayani, and hello viewers. It's wonderful to meet you through this medium. Unfortunately, I'm not on Facebook and very little on YouTube, but through Sanjay and RSSDI, it's my pleasure to meet all of you.
Okay. Now we all are aware thyroiditis and thyroid disorders are one of the two most commonest endocrine disorders which we see in the population. Today, we will try and understand first basically about thyroid disorders, and then see how they are connected, and try to address as many questions which patients, as well as probably some of us practicing, have in common. So my first question to you, Dr. Sheshadri, is how common are thyroid disorders in the general population itself?
Right. So we need to look at this carefully. So if you just look at it, it depends on how you define thyroid dysfunction. So that is the first part. So there are two different kinds of thyroid disorders. Those are actually three, in the sense that one just causes swelling. The second causes the function to be low. The third causes the function to increase, right? Of which the function that causes the function to be low is the most common, right? And this is called hypothyroidism. Now, in hypothyroidism, there are stages. At a stage where where the disease is not manifested, is an antibody positivity, then followed by, in some of them, progressing to having elevations in the TSH, which is the hormone that controls the thyroid. And when you have the TSH is elevated, but the thyroid hormone itself is secreting normal, we call it subclinical hypothyroidism, right? And then, of course, everything goes downhill and you have hypothyroidism. Now, if you look at it, as someone who has clinical hypothyroidism, all the hormones are low, the TSH is elevated, then the worldwide the incidence seems to be around 0.3 to 0.4%, and up to 1 to 2.1 to 1-2% in community surveys. Now, if you look at, I'm looking at worldwide. From what we know, it looks like in India these may be a little more, right? Then, if you look at subclinical hypothyroidism, then this is much more. Remember that this is a condition where the TSH is elevated, which is the hormone controlling the thyroid, but the thyroid hormones themselves are not. So here you will find that around 4 to 10% of adults have hypothyroidism, right? Now you look at the antibody positive, which means that that the thyroid is being attacked, but the hormones themselves are fairly normal. Then that's around 11 to 12%. And this has been correlated in many countries. In the Indian context, you should think that these are slightly more elevated, but depending on where we are, this seems to be the general trend around the world as how these are. Now remember, what happens is in women, this is 5 times more common. Sanjay, are you there? Purvi is, I think Sanjay is missing, is he?
Probably,
Sanjay.
yeah, there he's back there.
Sanjay, you're back.
Yeah. I've heard, and I think there was some problem with the
Dr.
connectivity.
Sanjay,
Thank
it
you,
will
Doctor.
help if the video is off, maybe even when the connection is low.
Oh yeah, I don't know, but the connection was. I checked this very well. Okay, I'll put this off and I'll start off my questioning. The other thing which I wanted to ask you is you enumerated 3 thyroid disorders. One is low functionality of the thyroid, high functionality of the thyroid, and the thyroid swelling, which are the 3 most commonest disorders, and 3 most common thyroid disorders, and the commonest among them being hypothyroid. Now, now I want to know, is there an association? We know there is an association between thyroid disorders and diabetes. Now, how common is this thyroid and diabetes association? How common they do go? We know some people who have thyroid disorders develop diabetes later, and then that's an association. Or how common diabetic patients are diagnosed having thyroid disorders over a period of time?
So it's very difficult to answer that question from a scientific perspective, but we have answers. But the reason I'm saying this is something very interesting. For example, these are very common conditions. These are very commonly found in the population. The question is, are these together? Is one causing the other, or are they just found together? What we know is that if you have type 1 diabetes, that is the diabetes that occurs in children or adolescents, right? The
Yes.
second is that is caused by antibodies, and it can be treated only by insulin. That in patients with type 1 diabetes, this is exceptionally common. For example, you will if you look at patients with type 1 diabetes, many of them will have antibodies at the time of diagnosis, or even a TSH at the time of diagnosis. In these people, the relationship is very, very, very well established. In patients with type 2 diabetes, this relationship is not so well established, but we know that in patients who have complications of type 2 diabetes, who are very ill with type 2 diabetes, or those who have problems controlling type 2 diabetes, this association is probably higher. So to summarize, if you have type 1 diabetes, the risk of the coexistence of thyroid disorders is so common that we recommend that every year they need to get blood tests. On the other hand, in type 2 diabetes, that these are probably more common, but they don't require screening each time. They may, but actually be screened like a general population. But in patients who are at high risk for complications, patients who have uncontrolled diabetes, who have other comorbidities, it's a good idea to keep checking for thyroid disorders. So that's the way to answer this question.
Thank you, Dr. Krishna. You put this question to ease in terms of trying to tell the viewers that type 1 diabetes patients need to be screened every year for a thyroid disorder, irrespective if they have present symptoms or not. And if and they may have antibodies positive earlier itself during the start of the illness. For type 2 disorders, if they are having many comorbid conditions, they are candidates to be screened, or uncontrolled diabetes, or when you suspect they may have a thyroid disorder, you need to screen them, or probably once in 5 years, or whatever you would think is appropriate to screen them for thyroid disorder. Now, the other thing which is very common is most of the times we do not have patients presenting frankly with symptoms of thyroid disorder. They're very non-specific. In your experience and practice, what are the subtle symptoms and signs you want to tell this audience which you should look for and suspect highly in a patient who has diabetes, and you pick these signs and symptoms and say, okay, let me screen him for a thyroid disorder too?
So, so one of the interesting things to remember is what my boss and my mentor, Dr. Chuck Cannon, taught me. He said, Krishna, the symptoms of hypothyroidism are the symptoms of life. So it is very interesting because, so the thyroid is a hormone that affects every single cell in the body. What it does is it maintains the metabolism of each of these cells. It's because of thyroid hormone that we are able to be comfortable in our clothes, give the energy that we do for our work, be able to be functioning without depression, with having a good outlook. It's also responsible in women for the menstrual cycle. It's responsible for having babies. So there's not a single function that it does not affect. And therefore, if there's an alteration in any of these functions, in a child not growing properly, in a woman not having menstrual cycles, in a young person either being depressed, loss of hair, gain of weight, any of these are indications for treatment. While we tell that there is no reason to screen for thyroid disease, which means that everyone should not be just done a test. That's simply because I know many of us do, these master health checkups and mistress health checkups that are offered, and many of our patients come with packages. Remember that tests can themselves be inherently wrong. If you do 14 tests at a time, one can be wrong. So screening for, a battery of tests is not recommended. So in thyroid disease, there are some people who require screening, which means even without any symptoms, some women planning pregnancy, during pregnancy, older women, and even older men. And of course, I said all the indications in diabetes where you need to be treated. Type 1 diabetes tested, older patients with type 2 diabetes, maybe at 35 and then 5 years thereafter, there is some evidence to suggest that patients with complications and morbidities. For the others, it is only case finding, meaning if they our indications are if they feel slow, if they are constipated, if they are depressed, if they are tired, if their cholesterol is elevated, right? If they have difficulty getting up, or if they have pain in the muscles, each of these are indications for screening for thyroid disease.
Thank you, Dr. Krishna Sheshadri, for that.
Just add also in women, altered menstrual function is one of the most important reasons to treat, to screen. Infertility is an important reason to screen, right? So if you have multiple pregnancy losses, you have to screen. And of course, in every pregnant woman, you have to screen.
Okay. Now, we've got to this topic. It's very nice. And we see a lot of thyroid disorder, particularly more in women compared to men. So is there a particular reason for this scientifically, or it is one of the disorders which is more common in women?
You want the PhD answer or a simple one?
A simple one.
So remember that women are more predisposed to autoimmune disorders, right? So there is for example, when we are in our mother's womb, one of the things that happens is, the body goes through a process where it recognizes its own cells, right? And it's like, issuing an ID and verifying it, like an Aadhaar card verification, correct? So what happens is that in men, this process is a little more complete than women, right? And therefore, women have a slightly higher incidence of autoimmune conditions. One of the autoimmune conditions that is increased in women is thyroid disorders, right? And this is one of the reasons. So this is one of the biological reasons why women have more thyroid disease. Also remember that if you have a family history, then you can have more thyroid disease. You have certain other conditions, for example, gout, right? Other autoimmune conditions, you can certainly have thyroid disease. And remember, type 1 disease is many times due to an autoantibody. And that's one of the reasons we screen for thyroid disease. Women with disorders in menstrual cycle, some of them, who have a condition called Turner's syndrome, where they don't menstruate regularly, they do not attain puberty, where they are at a higher risk of thyroid disease. In some, you will see a high risk of thyroid disease in some other congenital conditions like Down syndrome. Each of these, it's a very common condition. Women have them a little more.
So the most important thing for viewers to know is you should have high suspicion of thyroid dysfunction in anybody who are walking in, if they have any of the symptomatology which Dr. Krishna explained, of any of the symptoms which he narrated to, and women are more prone or they have a higher incidence of thyroid disorders. So taking this forward, one of the most common disorders is hypothyroidism. And many of these patients, most of the time, a common question comes in, which is the best time to take the pill? Now we all understand this is a very common one, and I see most of them may get it wrong or may not follow exactly why they should take it, where there is because the drug interferes or something else. If you take it along with it, interferes with absorption. Can you highlight our viewers when is the best time to take the drug? What are the drugs which interact commonly when you take a hypothyroid replacement pill?
So this sounds like a Viva question in my final exam, but first thing is, I don't blame patients. When you have a chronic disease and you have to get up day in and day out, and then start taking medications, then it's difficult. Remember, doctors are the worst patients. But when it comes to taking thyroxine, it's important to remember that the stomach needs to be sort of empty for its absorption to happen well. It gets absorbed in the stomach pretty much. And therefore, you need to have your stomach empty. So the best time to take it is the moment you wake up. So some patients, religiously keep an alarm at 5:30 in the morning or 5 in the morning or 4 in the morning and wake up. You don't have to do that. When you wake up, take the drug, right? That includes if you're a shift worker, when you wake up, take the drug. Now, there are a whole bunch of things that people will say, half an hour, 1 hour, 45 minutes on. A reasonable amount of time would be 30 minutes to have your cup of coffee and then follow it up with breakfast a little later. There are many drugs that interfere with it, including, some of the common drugs that we use. The most important one, I'm sorry about the vendor in the back, the most common drugs that interfere with these are iron, which a lot of women take, and calcium, which also a lot of women take. So one of the things that I tell patients is take the thyroid in the morning, your iron and calcium at night, right? So the smart way to think about it is, for most drugs, make sure you have at least 6 to 8 hours of difference between taking the thyroxine and your drug. Now, many of the people who logged in today are probably diabetic. So take your thyroid in the morning. You can go ahead and take most of your diabetic patients, except metformin, which reduces the TSH, but it does not interfere with the absorption. So you can take it with breakfast, your other medications. But the moment you take thyroxine, wake up, take thyroxine. Now, rarely there are patients who cannot take it in the morning. In every one of our homes, there is a 5 o'clock syndrome where we have to get kids ready and all that stuff. That's one reason. But most importantly, some of them feel nauseated in the morning. They have severe nausea in the morning, like in pregnancy. In those rare conditions, what we tell patients to do is take it at bedtime. That's fine. Make sure you take it on the same day. This is a rare thing that you can discuss with your doctor and do if you're not absolutely able to take it in the morning. For most patients, it should be on an empty stomach. There are other drugs like old cholesterol medications, aluminum hydroxide, all of that interfere. But the commonest ones are calcium and iron.
Thank you, Dr. Krishna, for giving a clear answer to everybody when they should take the drug. What are the drugs which interact, and the common ones which interact? And if they are diabetic, they can take their pills, and also in highlighting the fact that metformin can reduce TSH to a certain extent. Now, the next question which comes to my mind, the most common one, which most of us doctors as well as patients come with a value, or with a thyroid profile, whatever you call it, because of excessive testing. Welcome, Dr. Bansi Sabu. Dr. Bansi has joined us live. So there's one of the commonest thing which happens is you find just an elevated TSH, as you were telling, the most common thing which we say. The 3T, T4 is normal. You just have an elevated TSH, but not in the range where it's symptomatic. Just did a test out of curiosity, got his TSH, which is slightly elevated, whether he's a diabetic, not a diabetic, normal people who walk in with this test and they find it slightly higher, they come to you, or what we call subclinical hypothyroidism. Now, when do we treat these patients? Do we treat all patients with just a value which is out of range, or are there specific conditions and reasons where you have to treat?
So let me first plug my my pet peeve, and that is, do not order a drug test unless you need it. This is the first part. The second to your patients is, don't go to a lab and get all the tests you want and then go to a doctor. I think laboratoritis is probably the most common diagnosis that we see in practice today. So remember, a TSH for you may be a normal TSH for me. An elevated TSH for you may be a normal TSH for me. Let me give you examples of this. As you get older, the TSH actually slightly rises. For somebody who's 90 years old, a TSH of 6 or 7 may be something that's completely normal for you. If you're very obese, your BMI is 25, 30, 30 or 35, you may have a mild elevation of a TSH that's actually normal. It's not the TSH that's causing the obesity, but the obesity that is causing the TSH elevation. So remember that a test is useless unless there is a clinical context. Never start a drug or anything unless you've discussed with your physician and the physician has made a diagnosis. What do I do when I see a small elevation in TSH? It depends on what is a small elevation. Most of the time, if the TSH is more than 10, then it shows that the thyroid is already progressed to a point where it requires treatment, and therefore most of us endocrinologists and diabetologists and physicians would start thyroxine. This is a clear-cut thing. But let us say the TSH is 6 or 7 or 4 or 5. Should I do it? The most common response in most of our practices, wait and repeat, right? A very mild elevation in TSH is not an emergency. It doesn't require you to start treatment. Wait and repeat it. I think if your doctor advises it, that's a good thing. The second thing is that there are some conditions where we decide to treat very early. In most of our patients, I just tell them to wait. And 2 months later, you'll find that it either goes up or it goes down, or and it becomes normal, or it remains the same. If it remains the same, I will continue to watch. If it goes up, I would treat. If it becomes normal, I shake hands and leave. Right? But there are some conditions where you would want to treat. For example, if somebody is planning a pregnancy, if they have infertility, these are people that you really want to treat. Right? Other than this, there are some people who treat it for lipid elevations, or if the patient is very symptomatic, or if there's coexisting depression or others. Usually it's a clinical call. But a mild elevation of TSH is something that has to be followed up, and some people would even treat it if the antibodies are positive. But the truth is that if you look at this carefully, all you have to do is to have patience and wait with your doctor as he follows you up, and not necessarily jump and start treatment. Some people are very symptomatic with their symptoms, and in their a trial of treatment is a good idea. And then after 2 months, see if taking the medication actually improved the symptoms. If it didn't, then your doctor would decide, okay, why go through this again and treat it for? As I said, the symptoms of thyroid are many times the symptoms of life. So it is really a contract between the physician and the patient, and to individualize the treatment based on the condition of the patient. If somebody's TSH is really elevated, they absolutely warrant therapy. If they require fertility, pregnancy, or any of those, absolutely they should be treated even for mild elevations of TSH. But for most of our patients, I think a good follow-up is all that's required.
Thank you, Dr. Krishna Shadri, for wonderfully illuminating that when your TSH is slightly higher, T3, T4 are normal. Just don't worry or panic. And there are certain conditions where your TSH is elevated, but in those conditions where absolutely necessary, like infertility, pregnancy, very symptomatic patients, or somewhere where the physician feels that he needs to give a trial for some period and then takes it off. Thank you very much for telling us when to treat patients with a mildly elevated TSH. Now, one of the commonest questions is, does thyroid disorders affect glycemic control or blood glucose values, both hypo and hyperthyroid, since it's linked together? Does these two disorders cause abruptions in blood glucose values?
Absolutely. So, for example, let me start with the easiest one. In thyrotoxicosis, the metabolism is so high that it is wasting away the body, and the diabetes is very difficult to control. In hypothyroidism also, there is some degree of insulin resistance that is involved. So diabetes does become difficult to control. So remember that restoring euthyroidism restores the homeostasis or the metabolic equilibrium of the body, and therefore it is very, very important to actually treat the patient and get the thyroid normal when dealing with a patient with diabetes. So definitely they do influence the glycemic control, and the magnitude may vary from patient to patient, but definitely it requires to be addressed.
Can we go to the next question? Dr. Bansi, are you there? I think I can ask Bansi to. Hello? Yeah,
Yes,
do. Welcome, Dr. Bansi, the president of RSDI, the brain behind this Diabetes Bytes program. Would you want to direct a question to Dr. Krishna, or should you look tired already? You have a long day. I saw you in a couple of meetings earlier. So, do you want to direct a question next to Krishna, or should I ask you a question?
No. So first of all, I want to thank Dr. Krishna. Recently, the guideline which is made by RSSDI thyroid guideline, and where the biggest contributor for that guideline, I must tell here that Dr. Krishna was there. So I must thank from RSSDI to Dr. Krishna for finalizing the guideline, and now guideline had already come. First time the RSSDI had taken this initiative to come out with a thyroid guideline, because the diabetes and thyroid is closely interlinked, and many physicians and diabetologists and doctors, they don't get the thyroid function test regularly as it is advised. And as we know that many of diabetic patients have abnormal TSH, or they have even sometimes subclinical hypothyroidism, and many of them have frank hypothyroidism and hyperthyroidism. Now, idea of this RSSDI social Bytes, as you know that, and you are a very active member of this social media Bytes, that we through this we want to reach to the lay people, and almost more than 10,000 persons are following us regularly, and many of them can listen it afterward also. So that's the idea. So Purvi is very active, Sanjay is active, and there are many more from our RSSDI who are very active in this social media Bytes. And our primary goal is that we should reach to the lay person also, because they are the one who should know more about the diabetes. We want to increase the awareness about the diabetes. We want that how diabetes can be prevented. As we also simultaneously recognize that thyroid problem is also very common. And as this time we had come out with the diabetes and thyroid guideline, let us keep one dedicated, this talk show only on thyroid issue, and which is very, very important. So once again, I am thankful to Dr. Sanjay, Purvi, and many thanks to Dr. Krishna, who is subject expert for this. So I don't want to ask you, please continue. I just joined as a president of RSSJ to this session.
Thank you, Dr. Mansi. Thank you
Thank you,
for the
Dr.
comments
Mansi.
and nice words. Now, I have another question. I keep on going because there's so many myths or probably so many questions patients ask me. I'm just directing questions to Dr. Krishna. Now, what is the approach? Now, in simple layman terms, one of the commonest thing a patient walks into the clinic is like, it depends on who they walk into. They walk with the swelling of the thyroid gland. Now, what many of them are afraid that the thyroid gland, the swelling has to go. Doctor, I need to get operated. Now, for laymen, with the swelling of this gland, which comes into your clinic, or what is the best way to approach this? The simplest, the best way to approach it, and how do you do it? Wanted to get your idea and thoughts to all the people around.
So let me tell you, start with telling people how to look for the thyroid. It's something that all of us can look for. All you need is a mirror and a glass of water. What you do is you lift your neck up, look into the mirror, then drink the glass of water or swallow your saliva, and see if there's a swelling that is going up or down. So the thyroid is a gland in the midline. It's a butterfly-shaped gland, and what you will notice when you swallow, not this which is the Adam's apple, but something below this, a swelling that goes up and down. If that is there, then you have a thyroid swelling and you need to see your doctor. This is the first part. When a patient comes to us with a thyroid swelling, remember that in the olden days, we thought that in pregnancy and others, that having a thyroid swelling is normal. We don't anymore. In the olden days, remember in Greece, in Egypt, when a woman would get married, they would tie a reef around her neck. And then, if she became pregnant, the thyroid would enlarge and the reef would break, and that's how they celebrated pregnancy. Everyone else would know she's pregnant, remember? But that's not true anymore. We know that a thyroid swelling is abnormal. It could indicate iodine deficiency, which is what probably was happening in Greece or in Italy, where all the Madonnas have thyroid swelling, not the other Madonna. So this is important. So if you see a swelling, it needs to be addressed. There are two ways of swelling is there. One is that it can cause a dysfunction, which means a change in the function. The thyroid is high or the thyroid is low. The second is it can have bumps and lumps, which are called nodules. Let me finish the bumps and lumps because it's a simpler one and we don't want to spend too much time on it. The bumps and lumps require an ultrasound. And today with an ultrasound, we can categorize the risk, whether this is normal, this is benign, or it's cancer. And depending on that, the doctor will put a needle into the thyroid and tell you whether it requires to be operated or not. 96 out of 100 times, we don't operate. The thyroid being up or down is determined by a single test that the doctor would do after examining, asking questions, getting a history, and the single test that they will do is a TSH. Sometimes they will do a TSH along with a free T4 to save you time from doing two tests at different times, because they are usually bundled and they're quite simple. The free T4 is a test. It's not free, but it's called a free T4, and it's done on the blood. And what it does is it tells you what is the level of the thyroid hormone. The TSH is a hormone that responds to the thyroid by going up or down. If it goes down, the thyroid is working higher. If it goes up, the thyroid is working lower. So just based on this test, the patient is able to tell you, the doctor is able to tell you whether your thyroid is high, low, or normal. If the thyroid is normal and you still have a swelling, the doctor may just tell you, reassure you, and just follow you up over a period of time to see if this worsens or becomes worse over a period of time. If the thyroid is low, then it needs to be treated with a drug called thyroxine. The thyroid is high, it requires medications that either include medications for 18 months or a treatment called radioiodine. So, but again, these are individualized, they're discussed with you, but it's quite simple. It is not very difficult, but it requires compliance and a long duration of treatment. Sanjay, I hope that answered the question.
Yes, perfectly. You gave in an approach, somebody walking with a goiter, with both and looking at hypofunction. If it is low in function, hyperfunctioning, how do we treat? I wanted to ask you the next question, but you told treatment for hypothyroidism being either medication or probably radioiodine, depending on the convenience upon discussion with the patient. And third is if there is a bad gland, meaning if it's bad or malignant, then you get it operated. Majority of the times, it is more cosmetic operations, which I see, rather than for the real reason then they have to get it. So I wanted to get that out to people to know that not all thyroid glands are removed. You need to know the functionality of the gland, then look at if they're bad, good or bad. Depending on it, your doctor will take a call. Thank you, Dr. Krishna Sheshadri, for this wonderful answer.
Dr. Reddy, if I may interject.
Yes.
I am just enjoying this conversation so much between the two of you. I have just one question for Dr. Banshi, and I'm really thankful that he suggested us to have this session today, and with Dr. Seshadri, one of the lead contributors to the guidelines and developers of the guideline itself. So, Dr. Banshi, I think that was quite visionary that because patients of diabetes often have thyroid dysfunction, and as physicians, not all are picking that up or even screening patients for that. Do you believe that, and this is slightly out of the patient league, but do you believe that diabetologists and physicians should be specifically trained on this guideline or this guidance that has been developed by RSSDI? Dr. Banshi?
I think he's not. Dr. Bansi, I don't think he heard the question. Dr. Bansi, there's a question directed at you asking the guidelines developed in association with the Endocrine Society and RSSDI on diabetes and thyroid. Do you think these should be propagated more? And probably, I think Dr. Bansi is busy and I'll answer this question. I think we should take this forward in terms of trying to propagate it more, and probably everybody should read on. They'll be available for everybody. You can go into the RSSDA website, and also the Endocrine Society of India also has a website. Everybody has this patient information, and also train. It gives clear guidelines with the level of evidence, if you've read them. And thanks to Dr. Krishna and the whole panel who put this together. There's level of evidence is a different, and each question which I'm asking, there's been level of evidence for all of them and what doctors need to do. Now, I'll take the next question. One of the commonest thing, what is the diet I need to follow for thyroid disorders? First question, patient walks in, sir, no cauliflower, no beetroot, no cabbage. What do I do?
On top of everybody's head.
So what I tell patients is, tell me what you don't like and I will ban it. So it's important to understand, that there was an old thing about, goitrogens and cauliflower and cabbage. My suggestion is not to burden patients with this. They like their gobi 65, let them take it. So there is no non-iodized salt available in the market. The government of India mandates iodized salt. So please make sure, that is not an issue. There is no need to tell them about a specific diet, and certainly they can have cabbage and cauliflower if that's what they like. The other important thing is that patients are very 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 clear about asking for a diet for thyroid. I tell them, remember that the most important diet is what you're taking for your diabetes, and that you should really be following that and not this. So I don't think there are any specific things that they should not avoid. That they should avoid. There are in thyrotoxicosis, there are some things, seaweed and algae. Those are very high iodine content. And I have seen patients. I had a patient anonymized, of course, who was working in Korea and started developing a passion for Korean pickle. And this patient had thyrotoxicosis that never got controlled, and then getting a dietary history and found out that he was actually getting pickles from Seoul, and I can tell you they're really yummy. These are seaweed and algae pickles, but they're just loaded with iodine, and it would never come under control. So there are restrictions, but I think with hypothyroidism, garden variety, no restrictions. Let them eat what they like.
Thank you. That's one of the commonest questions patients ask, and I hope people who are watching this program live or who are going to watch the recorded version, we don't have a diet chart for the thyroid disorder, but please talk to your doctor. If your hyperthyroidism or some other very rare forms of it is not getting under control and you're eating something which is as exotic, I know I love Korean food, no second thoughts about it, and the pickles are yummy, and not sure how much of salt there is in. Now, the other question, which most of the patients come in and say, "You're a hypothyroid. I've been prescribed this drug, and I've been told that I should take it for life." Now, this is a common thing which comes in. The patient comes in with this. So it's a disorder. They think they're going to be patients for life. If I'm starting it for 2 months for subclinical hypothyroidism, or in pregnancy and subclinical hypothyroidism. So there are two questions. One, should they take it for life? In pregnancy and hypothyroidism, you need to screen nowadays. All pregnant women are screened for thyroid disorders and also for glycemic disorders. Now, these patients, how often should they get if they're pregnant and having thyroid disorder, how often should they get tested and readjusted the dose of thyroxine medicine? And the other question, which is common, should I take it for life?
So the answer to the person who's just graduated from a DM course is yes, for life. But as my other mentor and friend, Dr. Prasanna, would say, that every time that the favorite thing that has happened to him in his practice was that that he would go at it, look at the thyroid, and say, "Look, it's wonderful. Remember, I told you you have to take it every day." And then the patient says, "Doctor, I've not taken it for 3 or 4 months."
Yes.
You will find several people who have remissions. There was a time when you would think that you would never have remissions, but there are some people who have remissions. But for the majority of us, especially those who have TSHs that are very high at the time of diagnosis, they really do have to take it for the rest of their life, right? Now, those of you who think, that should I take it or not take it? The correct answer to you is, don't make the decision on your own. Don't stop it abruptly because it can cause problems. But you can always discuss with your physician, are you one of those small people or one of the small group of people with whom there may be a remission? Usually what would have happened is the dosage would keep on coming down. The TSH would keep on getting suppressed, right? And these are the kind of people the physician may even think, oh, maybe she's recovered, and try to take you off the drug. Or may reduce the dose of the drug and see, the TSH is going up or down. But the one message that I have to give you is, never do this on your own. Never stop the thyroxine. This is part one of your question. So, but the majority of us are not so lucky. The majority of us have to take it for the rest of our lives. The second is about pregnancy. Now remember, we have swung back and forth on pregnancy for many, many years. What should be the right TSH? What should be the wrong TSH? All of that. We have trimester-specific TSH values. I can tell you that no two endocrinologists will even agree on what should be the right kind of TSH. Having said that, we know several things. One, that thyroxine is very, very important in pregnancy. If you're a patient with hypothyroidism, if your TSH is very high, it's unlikely for you to get pregnant. And if you get pregnant, you may have other problems that include malformations and pregnancy losses. So if you're planning a pregnancy, talk to your doctor and get your TSH right. Second, the moment you are diagnosed with pregnancy, the moment you have confirmed your pregnancy, measure your thyroxine and free T4 and TSH. They will change the test in pregnancy. From free T4, they will change it to total T4 and TSH. And discuss with the doctor what is normal and what are the normals that he's treating. So a lot of people, so there are some controversies between 3 and 4, and of course 4 to 10, but that's something that the doctor will decide and work with you. This is one. More importantly, for the first, if you're already taking thyroxine before pregnancy, they would try to keep your TSH less than 2.5 in the first trimester, less than 2.5 in the first trimester, and certainly less than 3 in the second and third trimester. But this is something that your doctor will work with you. The one thing that we need to do is to make sure take the medications. The second thing is get the blood test every month. This normally we will tell you if you start somebody on thyroxine, we won't tell you to take a test until 6 to 8 weeks, simply because it takes 5 half-lives for a drug to reach its steady state, and that's when we do the testing. Pregnancy is an exception, where most physicians will get the thyroxine levels and the TSH levels every month. So a pregnant woman is somebody who needs to monitor their thyroid carefully, get it tested every month, and talk to the physician.
Thank you. Yeah, that is fine. Thank you, Dr. Krishna Sheshadri, for that wonderful answer on what a pregnant woman with hypothyroidism should do. Keep the TSH according to different trimesters between less than 2.5 or less than 3, and take the test every month so as to adjust the dose of thyroxine. Now, the second question, and I got one in the chat box asking me, what is the recommendation for the type of salt to be used? Now, this goes back, and we've start talking about salt, and it goes back to a long history. Can you throw some light on this?
I've been asked this question so often. The truth is that I can't find an answer. The reason is, with universal iodization, there is no question of trying to choose your salt. All the salt available in India is leached sea salt. People have tried using rock salt, especially in Graves' disease, in thyrotoxicosis, where iodization can cause problems. But the thing is that most of us who practice endocrinology in the community just don't have a salt restriction on patients. We tell them, take the salt that's available, because only when you take excess salt you have an issue, right? The areas where we are worried about where it affects, are including the radioiodine uptake. Each of these are really not something that affects the patients on a day-to-day basis. So the simplest answer is use the salt that everyone else uses. That's what we do in our practice. I don't tell people to go to Rajasthan and mine some salt for us.
Thank you, Dr. Krishna. Use the salt which is available. That's the answer. Don't bother about what salt. Buy salt, whatever you're used to using, please use it. Now, and the other question which came in the chat box is, how does weight help the correction of thyroid disorders? It's either way. People did. I got this test because I was putting on weight. So everybody thinks it's thyroid of 5 is responsible for his weight gain, or if weight loss can improve thyroid disorders. So
I wish it were so, in the sense that every person. I'm very careful about not saying man or woman, who walks into my clinic with overweight thinks that starting thyroxine can solve the problem, and the answer is no. Most of the time, the TSH is 4.5 or 5, and it doesn't do this thing. On the other hand, let's say somebody is truly hypothyroid, long-standing, dry skin, obese. Then it does make a difference. That if you're severely hypothyroid, it does cause excessive weight gain, and it actually makes a difference. By starting them on thyroxine, they lose weight and they do very, very well. But for most of us, a mild increase in TSH that we find is just an accompaniment of weight gain, and it's not, and treating it's really not going to help us. And by pushing the doctor to treat it, the doctor's only treating himself and not you. So most of us have to lose weight the hard way. I also want to, if it's okay with you and Purvi, to add the dangers of taking thyroxine to lose weight. So you must remember that there have been several instances of people who have taken thyroxine for weight loss in the past, and there are some very famous stories that include the Bassett super incident in Japan, where people were taking excessive dose of thyroxine for weight loss and ended up. Remember, this can eat your bones. It can speed up your heart. It can cause arrhythmias. Do not do this. Thyroxine thyroxine is not a weight loss medication. It's not an antidepressant. It is not a feel-good drug. It is a specific medication that has to be used by a physician when he or she clinically thinks that you will benefit from treatment. I think that's very, very important.
Okay. That's a very nice answer. Thank you very much. Now, the viewers should note that do not take thyroxine on your own. Do not take high normal doses, thinking that you're going to lose weight. You may end up with severe problems of the heart, the bone, and probably end up in the hospital and spend a lot of money, and your recovery can take a long time. Don't take thyroxine prescription without the right dose without the doctor's recommendation. Now, one of the questions which comes up to me and my always probably, do you think that you knew every child born in this country should get a TSH?
Oh,
And
absolutely.
what day the mother should say, please do a TSH for my child. I know many of the hospitals are following, but still, we are yet there for universal screening of TSH in the newborn. What day is appropriate? And yes, you already answered saying that everybody should get it. What day would be ideal?
First, just also to say that, remember that an elevated that hypothyroidism is one of the most reversible causes of mental retardation in the world, and that's the reason we need to do the test. Every woman who delivers must be guided on this, and actually talk to her gynecologist about getting a TSH after delivery. There are two ways to do it. In the US and in most places where there's a state program, they will do a heel prick on the fourth day and get a TSH. That's the best way to do it. But if let's say, but what is happening in many hospitals is, because of insurance, people are not even staying for 4 days. So what you could do is, when before you clamp the cord, you can actually take the TSH and it's normal. When you clamp the cord, the TSH increases. So it depends. Since we don't have a national or a statewide, state mandated program, we can't. It is all individualized by various institutions. But it's a good idea to send it as part of the panel that is being done. Remember that the TSH level for a newborn can be slightly higher. It's not like it has to be perfectly normal. We even react only if it's more than 15. But we also look at other instances and repeat it. But clearly, this needs to be a priority in this country. It needs to be something that needs to be done, and every woman should discuss with her gynecologist. Please take my baby's TSH. Remember, you being hypothyroid does not necessarily cause hypothyroidism in the newborn or the neonate.
Yes.
It's just that about 4 kids in about 1,500 will have hypothyroidism, and that's a good enough reason to screen child.
So thank you, Dr. Krishna Sheshadri. Please note that every child born in this country, we would prefer, or all the data says that doing a TSH on the 4th day would help. Please ask and consult your mothers, parents, both parents. Please make sure that you get a TSH for your kid. If it's not done, you're expecting a child. And this was one of the results. Now, I have another question. Are thyroid disorders on the rise in our country? This is something which...
Well, I don't know.
I understand it's...
I don't know. I think what is happening is we are detecting them more often. We don't have an enhanced kind of national database where where we are able to pull it out and say, this is what's happened in 1977, this is 79, this is 85, this is 91. What's happening is that till very recently we didn't have access to thyroid function tests in many institutions. I think we're just picking it up a little more. At this point of time, I don't have any reason to suggest that that it's increasing. Thyroid CA, on the other hand, there is data to suggest that it's actually increasing. It's not just a pickup. It's a marginal increase, but it's still there. But as far as hypothyroidism is concerned, my hunch is that it's only an increased pickup.
Thank you, Dr. Krishna. That was wonderful. Now we're coming to the close of the program. I will get your final comments. And if Dr. Bansi wants to ask Dr. Krishna a question but I would ask you, and thank you once again for formulating the guidelines in association with RSSD and ESI, thyroid and diabetes guidelines. What do you what do you think we should do to propagate these guidelines more?
Well,
So,
as I
Sanjay,
said,
this
uh,
RSSDA guideline, 20,000 physicians are taking the copy of this guideline. It is not
very
only going to the 8,000 members of RSSDI,
Good.
but 20,000 physicians will be receiving the copy of this thyroid guideline, and maybe in this month only, so maybe in another 2 to 3 weeks, and it is supported by Abbott. So actually, they were not the who were making the guidelines. So they were not supporting our documents or the manuscript. But once it has been finalized, and then now we are talking to them, and now we got it around 20,000. They are buying the copy of it, and it has been distributed to all physicians who are not the member of RSSGA. So it will be going across the country.
Okay. Thank you. And I know one Dr. Krishna was one of the
okay.
earliest
So since
propagation.
Banshi is here, right, let me also say this, that I think there is also a need to further research on this, the influence, and that should be part of the. There is, when I reviewed the initial manuscript and then tried to give it a structure, the one thing I realized is how much we don't know, and that is the beauty of being a doctor and a scientist. You every day you feel humble that you don't know so much.
Yes.
And that's where research and the kind of research that RSSDI supports and propagates and does, that helps patients in their real life. So one of the things that is required, that at the end of all of this, is that we know some, we don't know a lot, and that comes from learning from our patients and learning from the kind of research that RSSDI supports. So this may be something that, when hopefully these guidelines are rewritten in a year or two, we
Yes,
would have RSSDI's own research that is coming into this, and that helps us with a lot of questions that are unanswered.
I fully agree with you.
Dr. Bansi, any final comments to close? We're end of the session.
So, I mean, because this is a social media bite, but we will be talking again to the Krishna on that what are the unanswered questions and that how we can answer in coming years. That is a separate topic. And then, how we can initiate some of the research which can be supported by RSSDA. But as you know, that the idea of this social media bite is to, sensitize the people about the different diseases. As today is very, very important, thyroid disorder. As we know that the number of persons suffering from thyroid disorders are almost equal that diabetes, or even it is more than what we have diabetes in our country. And still, people are not getting regular treatment. They are diagnosed late, or they are not screened properly. And that was the reason we had come out with a guideline. And that's the reason why we are doing a program for the lay person also. But one more thing, along with this guideline and with the social media bites, we can do from RSSDI, which we are looking for, that even with diabetes and thyroid dysfunction, we are going to make a educational pamphlet and education, that we can also circulate to all, physicians, and they can keep it in their clinic also. So it can be given from the clinic, something related to the thyroid function. So I mean, all physicians in India, we have more than 35,000 primary care physicians and physicians who are practicing diabetes and thyroid. I mean, they can be given. So that's my idea, that in future we are going to have again a educational pamphlet, and which can be distributed to all these doctors. Once again, thanks to Dr. Krishna for joining us on this social media bite, and thanks Purvi and Sanjay for coordinating it for RSG. Thank you. Thank you.
Thank you, Dr. Krishna. Dr. Purvi, you have some final closing comments, and we're done. Thank you, Bansi. Thank you, Dr. Krishna. I think I learned a lot today, and it's always a learning exercise. Over to Purvi to closing remarks.
I just have to say a big thank you to each one of you, Dr. Banshi, Dr. Krishna, and Dr. Sanjay Reddy for this excellent moderation, and for both our experts to, so beautifully and very simply, explain the intertwined conditions of diabetes and thyroid dysfunction for our audience. It was a beautiful, like a master class completely in, from going through each and every detail of the disorder. So, thank you again for your time, for your effort, for your vision in terms of the guidelines themselves, and then, how to further propagate the same, because not much is being done in that respect. So I think this will be extremely helpful, not only to primary care physicians but also to the second tier that is often managing both the conditions. So once again, thank you so much for this interesting session. And audience, thank you for logging in. And we will be back next week with some more interesting sessions for you.
Thank you.
Bye. Thank you.
Thanks.